depends on what has the patient already seen. So have they completed a course of methotrexate and recurred later on? Maybe you'd want to re-challenge them with a methotrexate-based regimen that has commonly been done. We now routinely use the BTK inhibitors for patients. This is work done that was spearheaded by Christian to look at sort of the biology to understand those. Those are pretty well tolerated in our patients and are easy to administer. And then, of course, consideration of clinical trials.
Yeah, absolutely. I think what matters or what's more important is the patient primary refractory? And if they did respond to frontline methotrexate-based regimen, how soon did they relapse? So if a patient relapses within less than 12 months after initial response to methotrexate-based therapy, then I'm usually looking more into BTK inhibitors. Lenalidomide is also an option that we've been seeing, and we've been using that too. If the patient relapses more than 12 months after their initial methotrexate-based regimen, then we typically tend to re-challenge them with methotrexate. But I think whenever there is a clinical trial option, that would take precedence over any of these approaches.
I think that it's really critical if you do have a refractory relapse patient is to restage them. Don't forget that they can recur in the eye, in the vitrea. They can also recur systemically. You do not want to miss this in your patients because it's going to drive treatment.
We do sequence these tumors, and for the first line, it doesn't really matter. But interesting enough, when we looked at the our single agent ibrutinib study population, we sequenced their original tumors. We tried to get some circulating tumor DNA at the recurrence, and that's usually when we see circulating tumor DNA. And interesting enough, yeah, if there was a MYD88 mutation or not, it didn't really matter. What we see is that even if you don't have a mutation within the pathway, you might respond to ibrutinib. So I would not shy away from a BTK inhibitor if there's no mutation in the pathway. There seem to be the combination of MYD88 mutations plus CD79B mutations might be more resistant generating because there's other pathways that potentially take over when you block BTK. No, at the moment, the only mutation, if I identify them as a CARD11 mutation, obviously we shouldn't use BTK inhibitor because none of the patients with the CARD11 mutation on this study had a very long or any response. And yeah, based on our experience, we use still ibrutinib most of the time because it's on the NCCN guidelines, so we can get our hands on it. I see more and more people using acalabrutinib, zanubrutinib. There's not a lot of data for these two agents for the CNS penetration. I don't think acalabrutinib has the best CNS penetration, but again, there's not much data on that. And we all obviously are working on or have been involved with the tirabrutinib study. We hope that we see the results of that study soon. I personally think it works equally or even better than ibrutinib, at least in that study population, that how it is defined. And it seems to be a little bit more tolerable because, as you all know, BTK inhibitor, ibrutinib, has cardiotoxicity with atrial fibrillation. And in this elderly patient population, it's sometimes a little bit more difficult. Then you have to anticoagulate, and then the BTK inhibitor also increased the hemorrhage risk. So it's if you have a BTK inhibitor, a next generation BTK inhibitor that has a better side effect profile that is preferred. But yeah, I usually use ibrutinib at the moment. And again, then there comes the dosing. We know that the higher the dose, the more you get in. I would prefer to use 840, but because of the doses available, usually I have to just go with the 560 dose level.
560. Yeah, and there's been long controversy. Unfortunately, the dose of ibrutinib or other BTK inhibitors has not been as much evaluated or optimized as FDA calls it.
Yeah.
Except maybe with the future ones developed specifically for CNS lymphoma, as you mentioned, we'll see more and more dose optimization and the schedule optimization as well, which is important.
So there have been a few times where I've used combination, but I've just found that the toxicity was a little high and patients have had difficulty tolerating it, mainly with cytopenias. So I have sort of leaned more towards using it as single agent. Sometimes I combine it with rituximab, but mostly single agent.
Katie, this rituximab business, there's always question on my rounds when I'm discussing management of these patients from the fellows usually. Why do you do it? There's like a blood-brain barrier. Do you still remember from medical school? They ask me. So what's your take on this? Does it penetrate?
Um, I hope so because we use it. I would say the best on that. I was trained at Stanford, where it was developed, so I guess I'm a little biased. But again, we use rituximab usually with polychemical therapy with methotrexate. We can re-challenge patients with it. I think alone as a single agent, it doesn't have a lot of usefulness. Um, but for as part of a combo therapy for polychemical methotrexate use and then later challenging, we have also done a Brutonib in combination with rituximab for patients. And I do think that they can benefit from that combination. Has that been rigorously studied? The answer is no. And a lot of the questions, because of the rarity of the primary CNS population, continues to be rare. But that would be sort of the. I know that it has had a dubious role, but we continue to use it, and I think it is effective.
Yeah, and maybe the brain barrier in a setting of active tumor is also more penetrable as well, which people bring up as arguments. So yeah, but you're absolutely right. This has not been really studied extensively.